Today we're really getting into the weeds on something specific. We're looking at the rules, the costs, the criteria really around the two main ways monitoring responses happen for residents getting tech installed.
Yeah, and this is super important because, getting the tech right is one thing, but figuring out who responds and how is crucial. It avoids confusion, unexpected bills, all that stuff.
Exactly. We're talking about who answers the call, basically, and who foots the bill. But before we even get to monitoring, there's the setup, right? Installation, risk assessments, what needs to happen first.
Okay, yeah, good point. Let's start there. Installation timelines. The paperwork says 2 working days or 10 working days.
Right, 2 or 10. What makes the difference?
Well, it's less about the tech team being ready and more about actually being able to contact the resident or maybe their family, their next of kin, someone to schedule the visit.
So it's a communication bottleneck.
Totally. You could need something urgently, but if your contact person is, on holiday for a week, that 2-day target is gone.
And someone needs to let the installer in, usually. Consent is key.
Absolutely. Consent first, always. From the resident or next of kin. And yeah, typically someone needs to physically be there to open the door.
Okay. And once the installer is in, what about risks? I saw something about damp.
Yes. That's a really important detail from the sources. Risk assessment isn't just about the person's health conditions. It covers the environment too. Damp is explicitly listed as a risk that must be noted.
So environmental decay, things like that.
If it could affect safety or how the tech works, it needs documenting. And if a risk isn't on the standard checklist,
What then?
staff have to use the other installation information box. They need to detail the specific risk and explain why the tech is needed despite it or because of it.
Got it. That paper trail sounds vital, especially if something goes wrong later.
It is. If it's not written down,
Yeah.
especially a known risk, the monitoring team is flying blind. It's a safety net.
Okay, installation sorted. Let's move to the monitoring itself. Option 1, family and friends. The free pathway. What exactly does this cover?
All right, the free option. Now, the sources are really clear on this. This is only for sensors, basic sensors.
Only sensors, not everything.
Nope. Think low urgency alerts, things a trusted person nearby could reasonably handle.
Okay, so what specific devices are we talking about here?
Things like movement sensors, door sensors, maybe pressure sensors on a bed or chair, enuresis sensors too, or those simple press sensor plugs.
And these can be set up to ping only the family member or friend.
Exactly. It bypasses any paid counsel service entirely, just alerts the designated person.
Right, this is the crucial bit then. What is absolutely not covered by this free family and friends monitoring?
Okay, big ones here. Falls wearables and Alexa-enabled devices. Those are out for this option.
Why? Because they imply a higher risk.
Precisely. They usually need a guaranteed professional response.
Yeah.
Which leads us towards the other option, the counsel one. But sticking with family friends for a moment.
Yeah.
Even if you can use this route, there's this concept of professional judgment about the responder. Specifically, their proximity.
How close do they need to be? Is it about living in the same town?
Not necessarily about the postcode, no. The term used is reachable distance. But what's reachable? That's where judgment comes in.
So it's contextual.
Very. The example given was if the daughter lives in Spain, she can't be the responder, obviously. Too far.
Right. Makes sense. She can't pop over if the bed sensor goes off at 3 a.m.
Exactly. So the professional doing the assessment, like a social worker, has to decide if the proposed friend or neighbor is genuinely close enough to respond effectively for that specific resident's needs.
So reachable might mean 5 minutes for someone very frail, maybe longer for someone else.
You got it. It's not just ticking a box saying friend nearby. It's an active assessment of suitability. And if they get that judgment wrong,
Could be unsafe.
potentially, yeah, that assessment and documenting it is key.
Okay, that's a really important nuance. Reachable distance isn't just miles on a map. Right, let's switch gears. Option 2, monitoring response by the council. This is the one that costs money.
Yep, the chargeable offer.
Who is this actually for? When does this kick in?
This is for residents who simply don't have anyone. No family, friends, neighbors. Or maybe the people they do know aren't reliable or aren't close enough, like we just discussed.
So it fills that gap when there's no informal support network.
Essentially, yes. Or when the type of technology demands that professional backup.
And which devices fall under this? You mentioned Falls wearables earlier.
Correct. So definitely falls wearables. Also GPS watches, for tracking location if someone is prone to wandering. And fire alarms linked to the system.
Okay, critical stuff. Now, the cost. You said it's chargeable. How much are we talking?
The figure given is £6.10 per week.
£6.10. And is that means tested? Does income affect it?
No. And this is a really crucial point. It's not means tested. If social services makes the referral, the charge applies. Flat rate. Doesn't matter about the resident's finances.
Wow, okay. Everyone pays the same £6.10 if referred by social services. That's surprising.
It can be. But the real issue, the thing that causes the most friction, according to the notes, isn't the weekly amount itself. It's the billing cycle.
How often do they get billed?
Quarterly.
Quarterly, so every 3 months.
Yep. And the problem is, people forget. They get the service set up, maybe don't think about it much, and then months later, bam, a bill arrives.
And because it's quarterly, it's not just £6.10, it's, well, a lot more.
Exactly. The sources mention bills ranging from £180 up to £240 suddenly landing on the doormat.
Ouch. I can see how that would cause disputes. People saying, nobody told me I had to pay.
Precisely the problem. Which leads directly to the next critical point. Documentation.
Proving the conversation happened.
Absolutely essential. Staff must evidence the charging discussion. It needs to be explicit in the notes. Something like,
Like what?
charging discussion completed with resident accepts charge. Simple, clear. Because the rule is, it's not written down.
It didn't happen.
As far as the process is concerned, yeah, it didn't happen. No proof the resident agreed to pay.
And does that include talking to family, too, if they were involved?
Yes. If family members were part of the decision making, the discussion with them needs noting too. It all has to be logged in the main assessment record, typically on the social care system.
Okay, meticulous record keeping is the only defense against that quarterly bill shock.
Pretty much. It protects everyone, really.
Now, you mentioned social services referrals being chargeable, but things are often integrated these days. What about health? Is there a difference if the referral comes via a health route?
Ah, yes. This is the interesting exception. If a resident needs council monitoring, and they have a specific health need, and they're already under a particular kind of integrated health team.
Like a specialist team.
Yeah, the documents call it a Health Oxleys team. If that team refers them for the monitoring,
Then
it's free.
free. Same service,
Yeah.
but free if the health team refers.
Correct. But the conditions are specific. Must have that health need, must be under that specific type of health team, and their need has to meet the health team's eligibility criteria.
Just like a social care referral has to meet council eligibility.
Exactly. Same monitoring center, same response, different funding stream pays for it.
So it seems like there's, well, almost an encouragement for social care staff to see if there's a health link. If a fall is maybe due to a medical condition, for example.
The sources definitely suggest a pragmatic approach. It mentions teamwork, discussion between health and social care colleagues. Basically, if you can legitimately make the case that the primary need driving the monitoring is health related, and the person fits the health criteria,
Then pursue the free health referral pathway.
it's about getting the best outcome for the resident, using the available pathways.
Is the referral process itself different then? You mentioned social care uses their system.
Yeah, it's completely separate, which can be a bit clunky. Social care referrals usually go via their main system, like Mosaic is often mentioned.
Okay. And health.
Health colleagues have a different route. They apparently download an editable letter from their system. Rio was the name used, fill it out, and upload it back there.
2 separate admin processes for the same end service, depending on who pays. Wow.
It reflects the different budget lines, I suppose.
And on the topic of admin, there was a practical tip for staff making these referrals, right? About not duplicating work.
Oh yeah, simple but smart. The referral forms often ask for risk details, care needs, stuff that's already in the main assessment.
So,
The advice was clear. Copy and paste. Don't rewrite it all from scratch. Pull the relevant info from the existing assessment into the referral form. Saves time, ensures consistency.
makes perfect sense. Don't reinvent the wheel for every form.
Exactly. Streamlines things a bit.
Okay, so let's try and pull this all together for someone listening. What's the absolute core takeaway?
2 clear paths. Family friends monitoring. That's free, but only for basic centers, and relies heavily on good judgment about whether the helper is close enough.
Right. And council monitoring.
That's the chargeable one. £6.10 a week, not means tested, billed quarterly, which can cause issues. This is for the critical stuff: falls wearables, GPS, fire alarms, or when there's just no reliable local support.
And the 2 biggest risks overall seem to be what?
I'd say, number 1, messing up the admin, especially forgetting to clearly document that charging discussion. Number 2, getting the physical oversight wrong, approving a responder who lives too far away to actually help.
Both have serious consequences. One financial, one potentially safety related. Okay, final thought then. We've talked a lot about that 180 pound, 240 pound quarterly bill shock and how the current fix relies on staff remembering to document a conversation.
Yeah, it puts a lot of pressure on that note taking.
So, thinking systemically, if people regularly forget about a charge over 3 months, what else could be done? Beyond just relying on staff notes, could there be, automated reminders, different billing options, ways to manage those financial expectations before that big bill lands, to reduce the stress and the disputes? Something to chew on, perhaps.
Definitely food for thought on improving the process itself. Thanks for tuning in to this deep dive.